Hello and welcome to the new episode of SupplyCast. Today we're doing another panel discussion. Today it's going to be on the document, Integrating Care, the next steps to building strong and effective integrated care systems across England. Another classically catchy title for a government document, paper, whatever you want to call it. I am joined today again by Richard Whiteside, Dan Tagg, Clara Pennell, and Keith Rowley. Last time we came up with a name for the group now of procurement professionals, didn't we? And I've forgotten what it was. Yeah, I'm sure
Richard came up with it.
What was it? It was quite clever.
A collaborative, wow. I believe he said.
Yeah, a collaborative of procurement professionals, which I think liked a lot. Thank you for joining us again in this little think tank we've created. Everyone's got their badges on, which is great. Which
adjust my camera.
Which you'll be able to see on the video version of this. I suppose then to start off, it's the same question we started off when we were discussing the green paper is, how much of a necessity, first of all, was there for this document to come out, would you say? Who would like to kick us off?
I'll go.
Clara. Or what are we calling you this week, Clara?
Craig. I'll score later.
Craig. Go ahead, Clara.
So, my view, and this is personally my view because of how we work, and we are quite collaboratively, we work collaboratively, I didn't see it as a necessity to come out, because I think we're all working in an ICS in some form and fashion. It might have needed a bit of a reminder of the benefits of an ICS, and if the public are reading that, then great, fantastic. But I think the majority of our NHS employees reading this, and I don't quite. It's not, for me, it's telling us already what we know. There isn't any additional guide. Well, there's some additional guidance, but I haven't got much more to say, and I usually have quite a lot to say.
Clara, can I jump in on the back of that, if that's okay? Oh, no, Craig, sorry, Craig.
Dan, but okay,
well, thanks. I thought it was the end of the story there. It just
no, I was going to try to add some more. No, it's fine. Actually, don't. Go on, Dan.
Clara's dropped her bombshell early, Dan.
Yeah.
I know. I better play clear up. No, honestly. I like the way they're trying to say this is going to be done as a system by default. That approach really tickled me, that it's not a system by default. We already are doing all of this work. Aligned capabilities, category-led, looking outwards, all of these buzzwords they've thrown into the document, we're already doing that. So what more? All they're doing is emphasising the great things we're already doing and approaching, and they want to actually build upon that and build upon the hard work we've already done from a procurement system-led approach. And I understand how they want to link it all in together, but some of the benefits I found quite comical when I was reading them. Optimized workforce, we're already doing that. Improved capability, well, do we not put everyone on training and development and improve the capabilities of the team? Great careers, I think we all would say we're all in a great career culture with everyone we're already working with and trying to improve the careers of our staff. And the last one was this empowered culture. That one, yes, how would that even fit? What is an empowered culture? That one really tickled me a lot.
Dan, on the empowered culture, I think this is where it's given more autonomy into ICS-led decisions, particularly in procurement and funding. That's how I read it. But I mean, we already, this isn't unknown to us, but no. I think this paper's beneficial to the public, if I'm honest, not to individuals such as ourselves.
Yeah.
But I'm not knocking it. I'm just saying
And did you all find that what I found was the immediate actions, and it is expected these actions will happen within the next, starting from the 1st of April. I found that the wording of that was quite leading to say you must do it rather than is expected. Especially with you must have a procurement leader in for the whole ICS from the 1st of April or working towards. And again, with all the other elements around an MOU, key data sets. You have your own procurement forums, all of those parts as well, which most of us are already doing.
Which they are. I think, I'm going to, after this one sentence, I'm going to let everyone else speak, sorry. I think they need to be clearer on how they're going to support. So in procurement, where you're working as an ICS system, what model are we taking? So I've been to my guys across Bob today, and it's, are we taking a full ICS system, procurement system, and it becomes a shared service? No. Are we picking certain projects and categories and working towards one shared system of, like, you know, stock inventory management, procurement team? That's actually a big piece of work for those who aren't in that space, and most of us aren't. So it's quite woolly in terms of direction of travel, how much you want us to integrate in terms of personnel and system, not the IC system, but actual application systems.
Richard, Keith, did you want to add anything to the opening salvo there?
Yeah, quite happy. Echoing some of the bits there that the guys have said around the sort of the ambitious dates that are laid down, that in the next 4 weeks there'll be various tasks to get connected underway, and then within 3 months we'll be getting informed, and in 12 months time we should have it all done and dusted. So I think that's quite ambitious. A bit of a spanner in the works from my perspective is the NHS white paper that Secretary of State announced a few weeks back, where he was redrawing the ICS boundaries, because it says in the white paper that ICS boundaries are likely to be coterminous with county boundaries. So in Essex at the moment, we have 3 separate ICSs. We have one that covers Mid and South Essex, we have one that covers North Essex and Suffolk, and we have one that's West Essex and Hertfordshire. So we're going to have to redraw those ICS boundaries if we're going to adopt the ambition of the NHS white paper, which I suspect will trump this ICS plan. So it might be a little bit ambitious to get these things done now when the ICS boundaries are going to change. So that's one thing, just to throw a spanner in the works. I think also what Clara said there about collaborating on certain categories certainly makes sense. Trying to go to one procurement leader across the ICS and like a shared service, I think, is a real challenge, particularly when you're trying to merge into that community and mental health trusts. Having worked in basically all sectors, the requirements we have in the mental health trust are so different to anything you'd see in the acute. If we pull together our SIP plan and our work plan, there would be very few projects on there that would touch all of those types. So it is a challenge. I can see some benefits from it. I think there's some good stuff in there, but let's hear Keith's view, because I think again, some of it also is a little bit like the plans when the collaborative procurement hubs were first set up, looking at having joint work plans, developing people category led. So we had the collaborative procurement hubs, which they tended to be multi-regional, multi-county. This is now looking more like at a county level. So yeah, I'd be interested in Keith's view from a collaborative's point of view.
Yeah, thanks, Richard. Nice segue in. From a collaborative's point of view, I think it presents some really interesting dichotomies. I wasn't here right at the start when kind of the old I came just at the end of the SHA model, and collaboratives had existed for sort of 3 or 4 years before. And I look at the journey of what that original intent was to where we are as organisations now, and we ended up being we've ended up going in a different direction to that original intent, didn't we? I think if you look at East of England, NOECPC and LPP, we all ended up in a different place to some degree in pre-supply chain competing with that model, and in others not really working to quite that model. I think we're trying to do that now because it's the right thing to do as NHS organisations. I'm not sure that's quite always the case with all of us as collaboratives, if I represent that group. but it is an interesting dilemma. Where I started back with, so I agree with the comments you've all said. I would take it back a bit and play a bit of devil's advocacy for it though, because I think where I went with this was, if you take the PTOM guidance that was issued out for procurement, it starts with the ICS guidance that was issued for ICSs. And for me, there's obviously a political driver in that, isn't there? You talked about it in redrawing boundaries a little bit. There's redrawing of that, isn't there, Richard? In your area, I can see it in Yorkshire, actually, the debate about where Hambleton District, which is actually my local one, fits in. Does it fit into Wyatt, which is actually where it's aligned to as a trust? Or does it fit into North Yorkshire, where it's aligned as a county? So there's some problems to solving that. But fundamentally, that ICS driver of funding NHS England and NHSEI funding an ICS, and the funding is then distributed within the ICS. I think it starts with that, and the PTOM bit seems to be a process of taking all the good work we've been doing over time and learning from that, and trying to link that to the ICS agenda and saying, and here's a journey you can go on, so we can evidence we're already on this journey already. Where this leads to, I think, is the more challenging bit, because the policy direction seems to be, I'm not sure if some people actually, I'm not sure, to be fair to all people in NHSEI and others, I'm not sure they all agree, but if you take the political policy direction, there's a drive for efficiency, shared service in a more ICS-based capacity. I'm not wholly convinced shared service is right for everything. And I think that's, you touched on a point there. If we go ICS on shared procurement for all categories, we're all going to end up focusing on the big acute spend areas, because that's where the most money is spent, and we can all end up talking about clinical categories. And I'm not to demean that, but equally the spend we do on services in mental health and community are just as important. The spend we make on non-clinical areas are just as important. And if you do it and have it finance led, I think that's where we're going to meet some real challenges and frustrations. When I look at the PTOM guidance itself, which was the bit Daniel was sort of alluding to, yeah, I think there's some strange clunky bits in it, but it's trying to give us a set of tools to do it without mandating we have to. It's trying to find some flexibility, which I find encouraging from a national provider, because normally it's, you will do this and you'll all be in shared services by the end of next year, and we don't care whether it works or not, and it ignores all that practicality. I think they're trying to do it. Unfortunately, doing that, it's hard, isn't it? Because you can't make it fit everybody, and it's never going to appeal to everyone, is it? But I think we're on an interesting journey, and I think when I think about, coming back to your point, Richard, about the role of collaboratives, I think we're going to have an interesting journey in the future, which is bridging that. Where's national categories going, and how do we bridge that to regional and local? Because the new local is going to be an ICS. It's not going to be individual trusts, is it? If the funding regime drives the pound, and in my experience, the NHS, everything gets driven by the pound, doesn't it?
All right.
We've lost Craig.
So, yes, Craig's gone off on a call. Keith, I was going to say then, did everyone else seem to feel that there wasn't sure there was a need for this document? Would you differ with that? Or Richard, I suppose, Richard and Keith, you both?
It's not that I differ with the need for the document. I think the need, if you take it back to its root cause, did we need the legislative change they're going to drive at an ICS level? I'm not sure we did, in the way that they're doing it in that way from a finance perspective. I think there were some legislative changes required to make us more encouraged to work together in collegiate entities, and I think there were some barriers and silos that are practically need to be done. So in that sense, yes. My challenge with that, though, is I really feel a lot of the ICS agenda is politically led, and therefore I don't agree there's a need for it, because when politics gets involved in health service, it creates some strange things, and I think politics is going to have more of a role over the NHS, and we've already seen that. So, and I don't think that's a great thing from where I sit. But Keith, I do think some of the PTOM guidance on procurement could be quite useful if applied in the right way, and I think it's trying to be flexible, if I'm in defence of it a little bit.
Keith, what I was going to say is that it's not a one size fits all at this moment in time for everyone, because we're all at a different point of the journey for the ICS, but also there's a lot of trusts which are smaller, larger, so everyone's going to come up with this at a different angle, and it's not going to be able to be delivered. But it's also the wider impact about what they see the whole integrated care system model as being and they think about how it's going to link into social care, into the councils and those other parts which we haven't touched on yet, which you can see they want to bring in the future as well. So it's how you then align one structure and sort of sandwich it in with, okay, what are the councils doing in your local area? How is this going to impact? Or does that actually bring in the fire service and the police at the same time? There's many levels to these layers which all add into the whole agenda of this whole integrated care system.
It's the point of ICS, isn't it? It's about patient pathways. And if we can champion that at some level from our side, great. By the way, can I just apologise? That was the vaccine centre on the phone. I had to get it.
Yeah, fair enough.
I love it.
But you have to get the vaccine, or you just had to answer the phone.
I think there's a real nuance in this. I think the PTOM guidance is a piece of work they've been working on for a long time, isn't it? And they've linked that to ICSs. It's actually a lot of the replication of the good practice that goes on in trust, which is why we're kind of all looking at it going, well, it's not really telling me anything I know. Most of you are already working in some sort of acute setting at a trust level. You've already got some sort of nominated head of procurement to lead that as a group. Therefore, you've already ticked that box. You've got probably some sort of terms of reference that represents it. Most of those things are ticked because largely it's a replication of the good things we've been doing, and it's tried to come at it from that perspective, which hopefully is a positive. It just means we look at it and go, it isn't really telling me anything new to some degree. I think the flip challenge is where the political agenda is going to drive us and what that's really going to mean for us. And if funding becomes ICSs, a mental health and community trust is going to get a bit marginalised because everyone's talking about a shared service in back office, procurement, HR, or whatever it is. And actually, what behaviours is that going to drive when it really comes to the ground when that legislation comes in? Hopefully, this kind of approach through PTOM might help us find what we know are the smarter solutions to that, because acute won't go, I know how to deliver mental health, and mental health won't go, I know how to solve the acute side of things. But it is, and therefore in those senses, it is about collaborating, isn't it?
Yes, yeah.
But you can have specialist categories as well. So you could have a specialist mental health category, which then, if there's anything that does fall out around common products and services, you could link in with the acutes, but then it has its own remit and focus.
Correct. Do you think this is a drive towards more nationalisation of some of the control on what we're allowed to do and how we're allowed to do it? Do you think that's in the writing? Because we're already being sort of mandated to use supply chain, aren't we? Is this another route to that in the longer term?
We can speculate and assume it is, but
Keith loving hand grenades.
Well, I don't know the answer. I honestly don't. I'm not sure some of the people we talked to around the PTOM programme, they've got that intent in their mind. But there's other people influencing it.
It can look that way, can't it?
Keith, sorry, Clara. I was going to say that if you look at all the different PTOM work streams and how they're all going to come together in the future, you can see there's an undercurrent of, we all want you to become some sort of semi-autonomous bodies within each of your own areas, but with national oversight and control. So if you look at it, where they keep mentioning all the GCF, government commercial functions, those who know what GCF is, for the rest of the podcast, they are trying to line us all to use those methods, and that's the roadmap which they've got in the back of the head. You can see it within some of the documents, the other PTOM documents as well. That is the sort of push.
But then that contradicts what they're trying to do in terms of the procurement skills development and career pathways, because no one's going to want to join a procurement function in NHS if they've got a lot of the power and the autonomy stripped away from national. Because that's not a true procurement function in my eyes.
Yeah, but is that perspective of where, if you read all the different documents, I don't know if you've seen all the different workstream documents, then you read them all. They all say different. They all say minutely different things.
I think the thing is, though, talking about procurement development and people development, if you've got a fairly standardised structure in all of the trusts or all of the ICSs, which is where this is kind of heading, I think it makes it easier for staff to move through the career ladder than it does at the moment, because everybody's got these weird and wonderful different structures. Different titles mean different things in different organisations. at least if you had a real sort of blueprint for an ICS procurement department, it would be much easier to plot your way through how you get up the ladder. And I think that, and I think there would probably be more opportunities for staff to develop as well. It's just the feeling that I get. I don't,
it's definitely happening. There's a people
yeah.
work stream, and
Yeah,
they are
there
lining
is.
it all.
Yeah, I agree there needs to be a standardised form in terms of career development and personal professional development. But I also, if everyone starts doing the same thing and we all end up with the same set of skills, the same qualifications, then we've got, for want of a better word, we've got a team of robots. We need different people, different skill sets coming from different backgrounds, and then you can lead on to you can go on to different fields within not just procurement, but obviously commercial I think covers some of us, but ops or finance, or if you want to become senior leaders or exec. And I think there needs to be some diversity within that too. And I mean, the guys that I work with on some of those working party project groups, I think they understand that, but we need to, I think if we talk more openly about it, we won't go into that, in my view anyway, that kind of space of almost draconian, this is what we're going to do, this is what you're going to learn, and that's how you're going to progress your career with no flexibility whatsoever.
You are right, Clara. You need those transferable skill sets, and where you can pull them out of where we are now and move them into another function with some minimal training or upskilling.
Yeah.
I think that would be beneficial.
I posed kind of somewhat of a controversial question, and it's not necessarily how I think, because actually, Clara, I think you hit the nail on the head with that. I think there are some things that it makes sense for us to do nationally, doesn't it? We need a more centralised learning roadmap. There's some anxieties, as Daniel's talked about, in terms of linking that too much to GCF, and what does that actually mean? But if you take it practically, it is about giving us a learning journey roadmap that we can all go, that allows staff to move. And I think some of those things are good. As a hub, trying to work collaboratively with different organisations, some of the systems agenda around driving standardisation systems. I know they've talked about trying to advocate Atomis in the PTOM plan, as well as no one's procurement system is perfect or going to fit everybody, but we do need to try and move on some standardisation journeys associated to those, because data across this NHS system is really, really tricksy and difficult, and everybody doesn't have that maturity because people don't. Some DOFs or some financial controllers don't always place the same value on it that we try to convince them to, and I know we've got a role to play in that. I think there are some things that do need a bit more central category direction on, don't they? Look, we do it in workforce where there's more encouragement and strength to the arm to make sure expenditure is compliantly managed, don't we? Through the guidance issued by NHSI, and I think that gives us more arm to make sure it's properly procured, properly audited, properly supplier relationship managed, etc. So I think there are some things that are good, and I feel the PTOM journey is trying to go on that. It's that conflict though with the political interference in the ICS agenda that then drives the finances that adds a complexity into that sometimes makes it harder for us to actually do what's right for each ICS area. I mean, yeah, and if what comes down in legislation is, well, NHSEI are going to distribute it, and we want finance people within led from acute lead, which is what I believe the guidance said, to deliver the finances out to that ICS, you're going to get some strange behaviours within the construct of what that ICS is, because it's more than just the acute sector, isn't it? It is mental health, but technically an ICS should also include health and social care and councils and all the rest of it. So,
Exactly.
And we're miles away from that. I mean, we're miles away from acutes being really collegiate or mental health being really collegiate, because we're so different in our individual organisations, aren't we?
Yeah.
So how are we going to suddenly, in a year's time, be in an ICS model, working nicely with our council colleagues, and their expenditure is quite different to ours, to be fair to them as well. So,
what did you think about the timing? What did you think about the timing of this document? If I might pose a possibly loaded question.
Are you talking about the news, Bruce?
Well, I'm just wondering whether, you said, like, the initial question was, why, was there a need for this document? And it was kind of the panel, the good people of the panel were somewhat split on that. So then the next question is about the timing of it. Why do you think this document has been released now. I'm kind of, it's not a hand grenade, but it's maybe I'm pointing in a direction where there is a hand grenade without actually throwing it in and inviting someone else to do so. Do you think there was anything in the timing of it, or did you just think that, it was just, why do you think we had this document? It's a slightly different question to, did you feel we need it? Why do you think we're getting this document now? Or is there no particular reason for why we're getting it now?
So if I start with that, I think the ICS paper from ministers, I think there's a political agenda for a time frame I don't really understand, but I think they want to influence more political control, and I think there's a driver for the Conservative government to do that, and I think that's what's driven the timing of that particular side of it. Can it all be delivered in 12 months? Well, the political changes can possibly, but it's going to be a long journey before we've actually got that operating properly, because it's a big machine you're talking about across the NHS, isn't it? It's a lot of people, it's a lot of finance, it doesn't move that quickly. The PTOM stuff, I feel there was a need, and I do feel there was a need for the timing of this, one, to link to that agenda and show actually there was some stuff that had come from all the PTOM work that's been going on for the last 18 months. And I think that timing presented a window of an opportunity and a pressing need to show us there was progress on that. And the other bit of it is I think there was a bit of time starting to be put to thinking about this post-COVID, although we're not out of it. I think people were starting to turn their minds to this in the hope that we would be out of it, and therefore they were starting to think about that. Where at a national level the pressure on COVID wasn't as much. We don't see that at the local level, do we? But I think at the national level there's a bit more headroom potentially, because there's not that political spotlight so much on you haven't got enough PPE, Boris, what are you doing about it?
I think,
That's Craig.
Yeah, I was going to say before stuff. So if you reading on some of the comments on Twitter or my own social group on Instagram, Facebook, whatever, people have commented on the release of that green paper, and I don't know, not so much in ICS, particularly on the green paper. They thought, why is this happening now? Are they trying to cover up the bad press on PPE and the management of that? And why are we doing this change now when we're still in the middle of a pandemic? They're the two common themes I'm seeing. Do I agree with both of them? Not necessarily, but I think the timing doesn't look great, because it does look like that they haven't really tackled the lack of PPE or the PPE struggle supply chain that we saw the very first wave. It can look, I always think about what the patient and the public are going to perceive these papers, how it's going to be interpreted, and that's what I've seen from my side, and that's complete layman's term. They're not in the NHS, they're kind of looking going, what's that? Why have they done that now? And I understand, I'm with Keith on this, because we've come out of a pandemic. I think it was good timing, personally, and it shows that there is always time to reform, and why not now? Do it now rather than wait, given that we've just gone through such a heavy change. But there is also, on the flip side of that, we're tired. As a cohort professionals, we're really tired, and we need a bit of time to decompress, build ourselves back up again. And we've just now got another load of work we need to do that isn't necessarily always going to, what I mean?
That's a good point. That's a good point, isn't it? What is the, what is the desire or the, the drive to start getting involved with these kinds of things at this time? I suppose because
the energy for it, Bruce, is really tough, isn't it?
You need the will, but you need the energy, don't you?
And the energy is going to be really tough, isn't it?
Yeah.
Because it is really hard. People at local level are still very much in. Clara's just had to take a call on the vaccine centre. It's still very, very real on the ground, isn't it? PPE hasn't gone away. Vaccines haven't gone away, and they won't go away for another number of months. So we're still right in the middle of the day-to-day. And it's still hard work and tiring. So suddenly going, right now I'm going to think about strategic ICSs and the future and the grand plan. I think that's which is where I do come back to this Piton plan. It's quite useful in some senses. It's quite useful because it's trying to give us some ticks in the boxes that are quite easy to achieve, that we've kind of to some degree already achieved, and therefore we can demonstrate to our illustrious masters that we're sort of on the journey. But we've all, if we're to really take it seriously, we've got to turn our mind to a longer term future. So, and that as Clara said, we haven't got the energy for at the minute.
Yeah.
I didn't see anything devious about the release time of the paper, really. I think if it hadn't have been for COVID, we probably would have seen this paper a year ago, because Piton, they've been working on it for quite a while. So if anything, it's just come out probably 6 to 9 months later than planned. So yeah, I think they just felt that they needed to get on with stuff to try. You know, some ICSs have become quite developed in terms of their procurement sort of procedures and structures and progress. And I think there's not been a lot in some other ICSs. So I think this paper has kind of tried to get everybody on this, at least on the same journey, so that we do get some consistency across ICSs, because at the moment I don't think that exists. So
No,
that's all. Yeah. Look, poor old Dan, he must have something to say. He's never sat quiet for so long.
I have a lot to say on this.
I thought it was on mute.
I think Dan knows that it's getting to the point where I'm going to ask for scores, so maybe he was thinking of...
No, I'd like to just echo sort of what everyone else has said here, that its release is really open to individuals' interpretations. Yes, it should be released a long time ago. We knew it was coming. Sadly, because of all of the effects of COVID, it got delayed. And no, we also got to think about, yes, we had Brexit going on in the background at the same time in the middle of COVID. That has affected why we have now got the green paper, because we're outside of the EU bloc, we'll be on our own. So we do need our own rules and regulations which impact on delivery of procurement, not for just our area of NHS, but for all government functions and areas. So all of these things combined, the time is never going to be great. There was never a great time to do it. So it's open to perception. And yes, totally echo about having the energy to actually get on and do this, and the willingness to do it at the same time. And there's a bit of that capacity. You know, we're already doing lots of great work between us. There's so much great work we're doing, which is covered in so much of these areas. We just need to pull it all together and deliver it and follow some sort of roadmap which is laid out. I don't think everyone's going to be able to make the timings they're suggesting, not by a long shot. And there will be others that will, and there's others that would probably, I've already delivered this, but there'll be a lot that we are going to fall way, way behind on, because our priorities are just not here on this at this moment in time.
Because it's, yeah, I was going to, I don't know if this is going to probably be in lines with what you're going to say there, Clara, but I was going to say, it's interesting that you're talking about the energy, you know, there to do, you know, the spirit's willing, you know, but the flesh is weak sort of thing. As another part of the NHS, I was actually having a conversation with someone from Surgeons Union the other day, and they were saying, you know, about the pickup of planned surgery coming back after the cancellation of a lot of it and the backlog and all that. And again, it was on their side of the fence. A lot of it was about, you know, just simply finding the energy to play catch up with all these things. In terms of you guys, I mean, if there is that sort of thing about we're a little bit kind of in need of, you know, just a little bit of recharging before going into the kind of things we're talking about today. I mean, what is the answer to that? Is there an answer to that? Or is there no answer to that? Is it just kind of, well, we're just going to have to go back to the well again, or?
Well, the facetious answer, Bruce.
Go on. Well, we'd expect nothing else.
Big D and get on with it.
Yeah. I think we're going to have to get on with it, aren't we? I think as leaders, as heads of procurement, we need to make sure that, you know, our team have that chance to, you know, they take their holiday and they actually do rest. We don't work on our holidays, because we all know we're all terrible for it, and I'll put my hands up, I'm probably the worst for it. And I think we need to allow time just to think about things properly, not rush. because we could probably, as people who work in healthcare, we're really good in pandemics or when we need to fix something in an emergency, and we're probably going to continue in that train of thought. The problem is we're going to burn out. So we might go another year going, right, okay, now we've got work in the ICS collaboration, we're picking up BAU, we've got some great strategic projects, programs of work going on. And in a year's time or 18 months' time, there's real risk of burnout. And I think we need to make sure we've got the right sort of checks and measures in place to look after our teams and look after our people. Because, to be honest, none of, hey? Yeah.
And look after ourselves.
Yeah, I think looking at my foot, well, I've done too much, but it's really real, and I think that will become a problem. And not to mention, as some of the people have been, some of the teams and those guys in NHS have been in lockdown, been in hospital, but they've gone home on their own. I think we're going to see the knock-on effect of pandemic really hitting the NHS, and that's going to be maybe a similar level of front door activity or ITU activity, but for other reasons.
I should just perhaps add at this point that you've had a health problem with your foot, Clara. Otherwise, in isolation, in isolation, you brought it up there.
I did. It's just plantar fasciitis. It's not. I hope it's not going to get.
What did Clara say about her foot? I suppose it's a separate discussion, isn't it, about energy and going back to the well and finding time to recharge, physically and mentally. I think is a pod all in its own, and maybe that's something we'll do at some point. Just before we finish off the discussion, first of all, does anybody have any final comments on this particular document?
Yeah, I do. I think what NHSCI and PRIA and the PTOM team are trying to do is a good thing. If I really boil it down, I think the journey they're trying to take on is a better one. I think I've been in the NHS just over 10 years, and others have been in here a lot longer, but at least they're trying to engage with the local teams and work out what's the right way of doing things and trying to reflect that back. And unfortunately, that means it takes longer, and therefore we get a bit frustrated. It takes time to get the output. I appreciate that. But I do think I'm quite supportive of the general journey they're trying to take us on. There are things we do need to move towards. We do need a bit of support to make that happen, whether it's the people development stuff, and I'm really encouraged by the way that's going. I like the competency framework that we worked on with Daniel and others in that people work stream that Mark's been running. I like the way that's going and the direction of that. I think it's really positive. There are things we should be doing as more of a shared service. I think most of us would agree that there are things we could do better. We could have better standardized systems. It's hard for us to make the case for it, and we know the complexities and challenges in delivering it. In terms of so I think in that I kind of like the direction we're trying to go in, because I do think it's trying to take the feedback we've given and build that. Mm-hmm. Timescale wise, the energy point's a tough one. Timing feels difficult because of that point we've just been discussing around energy. Although my only reflection on that is I think we've got some early visibility of this, and generally my experience is national initiatives don't quite happen quite as quickly as they pertain that they will do. In fact, I'm trying to think of one that's actually delivered to the timescale it originally said without slipping by a year or two, possibly even longer, being the skeptic. So we've possibly got more time than we think there is in the guidance itself, but that doesn't mean we can be complacent on the laurels, and I think that's hard and I think there'll be some. My last comment was I think there'll be some strange curveballs at us, when the re-stand up of NHS has to recover all of those waiting lists that have been put to one side, and that reality really hits. I think some attention will get turned to those things, and this might fall down the priority list a little bit before coming back on the radar again. But I don't think this agenda's going away.
Mm-hmm. And nor should it, to be honest. I agree with you, Keith. I completely agree that I don't agree with some parts of both papers, as we know, but the principles of it sit with my principles of collaboration, engagement, working, because it sounds really cheesy, better together. But they're all it's kind of the spirit of healthcare and NHS and what we're here to do, and we're here for the patients and the public.
Yeah.
I'm going to stop talking because it's starting to sound really cheesy.
No, you're
Okay.
correct.
Does anybody want to add to the cheese quota, or shall I? I'm going to hurtle towards the finale, and I am going to ask you to put a score on this. And the reason why is because obviously we did it last time, and it's something for people to talk about on our social media accounts, aren't they? Who's the hardest to please? Who's the easiest? So
we know Clara's score then already. She's already got a 5 in mind, haven't you?
I think Clara starts at -5 and then takes it from there. That's what I've heard anyway. Clara, is it true that you got called the Craig Revel Horwood of the HSA panel on our Twitter last time?
Yeah.
Was it?
I quite liked it, to be honest. I thought it was a compliment.
You've embraced it. Really?
Yeah. That's why they call me Craig.
You dress up in glitter as well and then dance, and are you good on a ballroom? And does it, although is your foot holding you back?
Yeah, not at the moment.
Not the foot. No, I'm injured. I'm off.
Our next panel discussion will be solely on Clara's foot, the state of Clara.
Oh my.
No.
Points, marks out of 10. So Clara, Craig, whatever you want to be known as.
I knew you'd ask me first.
I'm going to ask Dan. The absolute chivalry of Dan Tag stepping in to give you more time to think.
I'll go first. I'm going to throw this one out there. I'm going to score this an 8.
Oh, wow.
Wow. Now the reason.
Yeah, go on. Absolutely.
The reason is for 8 is because I don't want to score it lower because it would take away from all the great work everyone's done which is already recommended in here. Yeah. So it's an 8 because it really emphasises everything that we've all achieved, either as individual entities, collaborative entities, all of that is all in here, and it's about just taking that forward and engaging in a different manner to make it, well, to change it into something that is a bit well-classed. I use that now. I'm going to use that today. There you go, throwing that one out there.
Nice.
So that's why I'm going to score it an 8.
So it's sort of crystallised what's been achieved so far, or the path that you're on for you.
Yes, and it's taken you further down that path and on that strategic roadmap to the future, but as a bigger entity. So the goal is really great, but we're all going to get there at different times, and we really should achieve that. And that's why it's an 8.
Okay, Richard, I saw you nodding at the 8. I don't know if that was in agreement or
in shock.
No. I was going to give it an 8 anyway. I gave the green paper a 7. The reason I've given this an extra mark is there's more detail in it. So at least whereas the green paper was just, lots of aspirations and they're planning on this and planning on that. What I like about this document is it does give us a pretty clear framework in which to develop the ICS. So a solid 8 from me.
Keith?
I feel like I have to disagree, but I can't. I was an 8. I might even stretch to a 9 if I was a little bit pressed. I think because it's our expertise. What you can't do is go beyond that because there's still so much detail to go. And if I was to talk about time, journey, and energy, you'd have to give it a lower score, wouldn't you? Because of that. But yeah, an 8. I can't see a different score personally.
Okay, I can only imagine the pressure Clara is feeling right now.
Been under pressure
after getting a trinity of 8s hurtling your way. I can only imagine the pressure as you slowly felt the urge to raise your score. But let's see how bold Clara is today.
Rendered speechless. I'm going to go. Okay, let's own this. I'm going to go 7.5. And because I think it needs a bit more detail and sort of aspirational, innovative focus to the ICS, because we're all doing that great work, as Dan said, and I love the idea of the ICS. I kind of embrace it here at RBFT. I'm about collaboration, about the system and the pathway for the patient as a whole, but there are other things that could have been included. And for someone like me, I think 7.5 is quite a good score.
I would say so.
You do half points. Are we allowed half points?
I'll let you have it today, just because I don't want to spoil the general positivity that we're going out on.
Mike Hallwood might be upset because he doesn't have 7.5 on his scoreboard because he has to have whole numbers, doesn't he?
I think we're going the Olympic diving route, aren't we, with the 0.5?
No, I'll give Craig a call. He might be able to do 7. He'll probably do 7.5 next time he's on the show.
I tell you what, I don't think anyone's going to be calling you Craig this week when the podcast goes out. I think you'll be safe from that, Clara. I think it might be back to Clara next time. Well,
there's some good points in what Clara. We know we're joking, but there's some really good points in that score because Clara said, we all have a good intent to collaborate, but culturally, I'm not sure we always get it right. Collaborative hubs trying to work in that space with the local and regional teams. There has been tension. It hasn't always delivered. It hasn't worked. Sometimes intertrust hasn't always worked, and there's tension there as well. So, I think some of the things we don't talk about enough probably are that cultural behavioural model. The guys on the call today are talking about it because they do that, but it doesn't mean everybody does it. And those are some of the things I think really do have to change if we're to deliver this. Culturally, how do we actually see ourselves as working together? But right across that system, whether you're acute trust, mental health trust, or you're a collaborative organisation, actually we need to say we're going to come together and work together rather than some of the behaviours I think we see at times, which is maybe not so supportive of that.
Yeah.
Great. Well, I think that's a good point to finish on, Keith. So it just really leaves me to thank everyone for finding the time again to do this. It's been really good. Richard, Dan, Craig, and Keith, thank you again for finding the time. As we've said, we've spent a large part at the end of that podcast, which I feel is really important, talking about your energy. But it's good that you still have the energy to, contribute so fulsomely in this podcast. That's really good, and I think there's been a lot of interesting stuff there. I think, what I think is important as well, from my point of view. I think everyone's speaking freely, which is a good thing as well. I think everyone's getting their views out. I think it's naturally been a kind of balanced response to this report, I think would be fair to say. So thank you, and thank you for finding the time to do this again. That concludes this panel session. It's our second one. I'm sure we'll be back to do another one before too long. I hope you enjoyed listening, and join us on the next episode of SupplyCast.